Hello, everyone. A warm welcome to today's ICS webinar on asthma COPD overlap. Usually, whenever we start the ICS webinar, I'm excited, I'm very, very happy. But today, we are not happy because we are extremely shattered and devastated by what has actually happened in Kolkata. A young, bright, lovely girl pursuing her residency in pulmonary medicine, our fellow colleague has been brutally murdered, and we know what other things also happened to her. Not just us, not only the medical community, but the entire country is completely shattered and devastated. Our heart goes out to her, our heart goes out to her family, her parents, and Indian Chess Society strongly condemns this brutal and heinous act of inhumanity, and we urge all members of Indian Chess Society and all the fellow pulmonologists to please join, come out, come out in the front, please. Please protest against this crime. Let's please take this march of getting justice ahead, and let's make sure that we can contribute in our every possible way to make sure that the unfortunate victim, our own colleague, gets justice at the earliest, and at least we make sure that such crime doesn't happen again, and we can provide better and safer working conditions for everybody. With this, I would like to request Dr. Nitin Abhyankar, our moderator for today, to please take over. Over to you, Nitin.
Yeah. I think we are all sad today, and all the same, the show must go on. I think our heart and our sympathies and our feelings and our determination, everything is behind the girl. And I think we will probably, it will be a long fight, and we will all fight it together. So let's stay together. Uh, Let me introduce the today's academic concept. As I said, the show must go on. And today we are discussing this. This is probably the 33rd, if I'm not wrong, the webinar series by ICS. And I must thank ICS and Lupin for this wonderful series which is going on. And today, what we are discussing is asthma COPD overlap. And this particular topic has been very close to my heart because well before the first statement, which probably started coming in 2015, I had taken serial lung function testing to ERS, European Respiratory Society, and we had presented around 120 patients in a poster where we had tried to show that what looks like COPD doesn't remain like COPD if I serially trend it at 0 months, at 1 month, and at 3 months. And in 120 patients, we could document that nearly 60% of them are actually were not true COPDs. So there remained the doubt whether we really call, what would you call that disease? When I first come across, it looks like a 30% lung capacity. FVC is 30%, FEV1 is also even lower than 30%. And then over a period of time, it changes. So I think that concept, of course, this today may be labeled, I think, and we will debate this as COPD-A, which is now the gold coined new terminology, but whether that is COPD or not. And I think who's better than Dr. Sanjeev Nair to talk about that? Can I have Sanjeev's introductory slide, please? Yeah. I think Aditi is talking about the logins. As far as I know, it was 1380 logins, and now I think the numbers are increasing. I think this is a phenomenal first that we have had. So I am sure today people are very, very deeply interested in this particular topic. And I invite Dr. Sanjeev Nair, who is a professor of pulmonary medicine, GMC Thrissur. He is the ZTF Chair, NTP SJ2, State Consultant for SWAS Kerala, member of Technical Expert Group for Chronic Respiratory Diseases and GOL, member of GBD India, member National Technical Expert Group NTEG as well as NTEP India, President-elect APCCM, Specialty Board Member for National Board of Examinations, has huge number of 76 plus publications, and he has written 6 book chapters. He has developed primary care level guidelines for COPD and asthma and implemented in the state of Kerala. I think Kerala has been ahead in most of the respiratory conditions for most of the nation, including COVID. Developed multiple guidelines for tuberculosis in India and conducted national level TB training in 4 countries. So, who better than Dr. Sanjeev Nair to talk about this very, very controversial and very interesting topic, asthma COPD overlap or asthma COPD overlap syndrome, whether he calls it as overlap or stops there, or he calls it a syndrome, he calls it a disease. I leave it to him. Sanjeev, the floor is yours.
Thank you, Nitin. Thank you for the kind introduction. Let me start by sharing my slides. I hope I'm audible.
Yeah, you are perfectly
Yes.
audible.
And that the slides are visible as well.
Yeah, they are.
Okay, good evening, everybody. So, I suddenly got a call from my very good friend, Dr. Amita Nene. And Amita said, Sanjeev, you have to join us for a program and give us a talk. So, you can't say no to Amita. So, I immediately agreed, okay. Then I asked, what is the topic? So she told me asthma COPD overlap. And I was actually traveling in an area at that time with no net connectivity and nothing. And when I heard the topic, I thought, okay, this is something that I've spoken on so many times in the past, like about 8, 10 years back. This was something like a topic which I was covering so frequently that I had all the material, everything available. But then I came back and I started preparing. I started downloading more and more new material. Suddenly, I realized that I walked into something that I was not very sure of now. The title that later came to me from Amita says that, it's asthma COPD overlap. All that you need to know. I'm sure that I will not be able to tell you all that you need to know. But then we have a eminent panel following afterwards with some of my seniors and juniors who are all very capable in the area. So I'm sure that at the end of the panel discussion, we'll definitely, we'll have a more of clarity, like the chair pointed out in the beginning. It's a bit of a controversial topic, and we'll deal with it as it goes. So, my mandate for the day, I mean, I've been given 20 minutes. I've kept a clock on so that I don't lose track of time. In the 20 minutes that I have, I hope to cover a bit on asthma and COPD and look at it on how same or how different they are. Is there an entity like this overlap syndrome that we are discussing today? How do we diagnose this? What are the management options and what are the current, consensus on the terminology, not on the management or anything like that? So the two
Perfect.
different diseases that we talk of, COPD and asthma, uh, you all know the definitions here. I'm sure that the large number of participants here know asthma and COPD in and out. The definitions, if you look at the first few words, it almost looks similar. You're talking of heterogeneous lung diseases, one of which obviously asthma is characterized by chronic airway inflammation. It's a syndromic, syndrome complex that you have with a set of symptoms which vary over time with variable airflow limitation and all that. On the other hand, COPD is something which is, which again has a set of symptoms, chronic symptoms like dyspnea, cough, and sputum production. And there is abnormality of both the airways and alveoli, which is described better in the latest, definitions that you have as bronchitis, bronchiolitis. Earlier, it was like chronic bronchitis and emphysema. Now, term bronchiolitis has also come in, which is persistent and often progressive airflow limitation. Now, the point here is that particularly if you look at the COPD definition, the world has come a long way and we come in a circle. So this was a kind of definition I learned as a postgraduate student when we did not have GINA or GOLD. And when we were reading Harrison's to get a definition for COPD, it again, those days, it used to be chronic airflow limitation due to chronic bronchitis and or emphysema. And the whole world, now we come a big circle and reach back to that old definition. So, the topic that we are going to discuss today is also more or less similar. We seem to be going in circles in that. Now, when I'm taking classes, I'm a teacher. I take classes for UGs as well as PGs. And when I'm taking a UG class, life is fairly very simple for me, because for UG classes, it's all in black and white. You want to make it as simple as possible so that your MBBS students understand concepts. You don't want to complicate it for them. So you try to keep it simple. The messages given to undergraduate students are that asthma and COPD are different diseases. Please understand, don't mix up the two. You have to differentiate asthma and COPD in the patients. This is important for you as a budding doctor, as a doctor who's going to treat these diseases, irrespective of whatever specialty you go into, because the prognosis is different. So when you talk to patients' relatives and you're trying to explain, your patient with asthma can be made almost near normal, whereas your COPD patient may progress with whatever treatment you give, and the treatment is different. And because of that, you have to make a good attempt to differentiate between asthma and COPD. Please do not club these diseases together and treat. So the message is very clear to undergraduate students because that is what you want them to learn. And then you give them a very clear message on how you differentiate clinically between COPD and asthma. Look at the kind of symptoms you're looking at, the history that you're looking at, and also in terms of spirometry. Again, you keep it very black and white. That if it is COPD, there is generally no reversibility, and if it is asthma, there is reversibility, which is often demonstrated. At the end of the day, we all know that life is not that simple. So at our level, when you're talking of pulmonologists, pulmonary medicine residents, consultants, these things are not very simple. So, your patient with asthma may be a smoker, may have biomass exposure. There may be reversibility in your patient with COPD. There may not be reversibility in a patient with asthma. So it's all, then it goes across and you're not very sure when you go higher up the ladder and then you learn more and more about these diseases. And that is what something similar to what we're going to discuss today. In terms of management also, it's quite, you make it dichotomous for your undergraduate students that if it is a patient with asthma, the patient should be getting inhaled corticosteroid. I think that this applies to all of us as well. So any patient with asthma, any management without inhaled corticosteroid is not good, which is what in tune with what Gina says today. And any patient with COPD should be managed with a bronchodilator, and inhaled corticosteroid should not be used unless indicated. There are very specific indications when you can use an inhaled corticosteroid for your COPD. Of course, when you go to various levels, you see that people break these laws very, every now and then, and you see patients getting the wrong treatment for both asthma and COPD. But then there is very, quite a bit of clarity on these two things, at least with respect to the treatment. But then if life was all that simple, we wouldn't be having this discussion today. So life is not in black and white. You have so many shades of black, gray, and white which go in. And then you have to pick up your bit in clinical medicine out of all those shades. And often there is not much of clarity on this. So from the very beginning, from the 1960s itself, when you started discussing the origins of asthma and COPD, there was these big two hypotheses, which the younger generation may not clearly know, but it's a good idea to know it. Please read it up. I'll not go into the details of it. So on one hand, you have something called the Dutch hypothesis, which looks at a common pathogenic mechanism for the two diseases, more or less saying that they kind of originate together. And there's even a concept of both diseases together called chronic non-specific lung disease. On the other hand, the British hypothesis saying that it is infection which leads to mucus hypersecretion and not, which leads to COPD. So both these things not so relevant today, but also relevant in another way. I've heard some of the big debates with Dr. Peter Barnes, debating against others, very senior people on these hypotheses on what is true and what is not true. But then, the point I'm trying to make is that from the very beginning, there has been lack of clarity on how it originates, whether there is overlap between asthma and COPD. When I was young and doing my post-graduation, this was one of the commonest, pictures that we had to learn. This used to be one of the short notes that used to come in our MD examination, the non-proportional Venn diagram or the non-proportional Venn chart, which is about three circles put together, one circle representing chronic bronchitis, another circle representing emphysema, and the third circle representing asthma. And you can see a rectangle there, which actually shows airflow obstruction. And you have various permutations and combinations, which you can see, as 1, 2, 3, 4, going all the way to 11 in this particular chart there. The point here is that the shaded gray areas that this is from a article in 1995, which came from the American Journal of Respiratory and Critical Care Medicine. So this 1995 article itself discusses areas in gray which are actually COPD. But then if you look at it clearly, you can see that there are cases where the asthma would overlap with chronic bronchitis, or your asthma could overlap with emphysema. And there are cases of chronic bronchitis and emphysema overlapping, and asthma would also overlap in that. So you have a small proportion. If you look at the number 8, it actually represents a group who have all three diseases together: chronic bronchitis, emphysema, and asthma with airflow limitation. So, the article was discussing all these various phenotypes and saying that, there is considerable overlap between all these diseases. So even way back as in 1995, this was widely discussed, and then the nomenclature and things were all discussed. But 1995 is another, big year for us, because that is a year when the first GINA guidelines were released. One of my first national conferences way back just after this in Bangalore, we had all the international big shots in asthma coming down. Those days we didn't have any access to internet, and these people came down with full booklets of GINA guidelines, which was one of our first booklets that we got, and some of the lucky ones amongst us got those books signed by some of the authors, leading international figures on in asthma, and we had autographed books on GINA, which came out in 1995. Of course, the gold guidelines came out later by around 2001 or so. So after that, every year you have been having these guidelines coming. Every year we all eagerly look forward towards the GINA guidelines to come out, to the gold guidelines to come out, to find out what is new in those guidelines. And we have been religiously following these. These are not really guidelines, as Dr. Salvi always reminds us. These are, workshop summary or workshop reports, which are to be taken not as guidelines, but general directives, which actually would help us to determine how we would manage a particular disease. Anyway, we keep calling them guidelines, and we've been following them religiously. What actually happened in about 2014 is when both these reports actually met. And suddenly we were all excited to see a report which had both GINA and gold put in together. So, the colors also, you can see that it goes from the blue of GINA to the yellow of gold, and some of the colors merge somewhere in between. And you had this report on asthma, COPD, and asthma, COPD overlap syndrome. That is what Dr. Nitin was telling us earlier. So what do you call it? So this new terminology, ACOS, came in, and then we were all very excited about it. So those days, talks were all on ACOS, why ACOS is important, and how we actually diagnose it, and how do we manage it, and all that. This is about 10 years back. So we were all very excited about it. This document very clearly told us how to, what are the features of ACOS, the definition. So the definition actually was talking of asthma, COPD overlap syndrome as something characterized by persistent airflow limitation, with several features usually associated with asthma and several features usually associated with COPD. So it's basically a condition where you have features of asthma and COPD. And, this entity was described, and the clinical features were also described in a table, which actually told you what are the features you get in asthma, what do you get in COPD, and what you get in ACOS, as it was described at that particular time. So one of the major things was persistent airflow limitation. Chest X-ray changes more or less similar to COPD, even though it would be normal in asthma. Exacerbation may be more in COPD, more than what you get in COPD, but would be more responsive to treatment. So many things, respiratory symptoms, which again overlap between the two. All those things came in. And they also gave you a table which actually would help you to differentiate between the two objectively. So generally, we all think of patients who have asthma, patients who have COPD, and where you get features of both. So supposing you have a patient with COPD who has history of allergic rhinitis, how would you take that? So, would you think of asthma? But here, there was clarity that you have your two set of symptoms on either side, one favoring asthma and the other favoring COPD. So, age of onset before 20 years favors asthma, after 40 years favors COPD, variability in symptoms favors asthma, persistent of symptoms, actually favors COPD, variable airflow limitation being documented favors asthma, whereas persistent airflow limitation favors COPD. Similarly, worsening of symptoms over time, progressive symptoms favoring COPD, and so forth. So you have all these things put together, including exposures favoring COPD and all that. Now, each of these things you're supposed to tick. So, if suppose the patient's age of onset of disease was at 15 years, you tick on the left side of the table. Then you have persistent symptoms at present when the patient is coming to you. Despite treatment, you tick on the right side of the table. Suppose the patient was a heavy smoker, you again tick on the right side of the table. So it goes on and on like that. And if you have 3 ticks on either side of the table, so you have 3 ticks for asthma and 3 ticks for COPD, then you objectively say that this patient has asthma, COPD overlap syndrome. So there was very clear objective way of diagnosing your asthma, COPD overlap syndrome. So, particularly for postgraduate point of view in an examination or something like that, if you vaguely make a diagnosis of asthma, COPD overlap syndrome, the examiner would expect you to say that there are 3 points on this side and 3 points, and these are the 3 points I got on either side, which allowed me to make a diagnosis of asthma COPD overlap syndrome. Now that went further. So for long, for another 2, 3 years, we are talking about this. Lot of talks, lot of discussion, lot of debates on this. Then suddenly, slowly this started coming under attack. The term syndrome started coming into attack first. So that came out in the GINA report in 2018, when they very clearly said that the term. If you look at the last line here, last point here, that the term asthma COPD overlap syndrome, which were used in previous versions of this document, is no longer advised. Their fear was that by using this term overlap syndrome, you're trying to make a distinct entity. So it's as if asthma is one disease, COPD is another disease, and then asthma, COPD overlap is the third disease. So they did not want that, and they wanted to insist that there is no separate disease entity, single disease entity. It's only a patient having COPD and a patient having asthma with a lot of overlap because of various mechanisms, and because of that, this syndrome should not be used, and the term ACOS, or the asthma COPD overlap syndrome, was actually removed in 2018. At that time, they continued to use a term called ACO, asthma COPD overlap, may be used because there is a need to maintain awareness that these diseases can overlap, and all regulatory needs of treating these patients and all are necessary, because generally all trials are done either for asthma or for COPD, and generally nobody does a trial at that time. At least they were not doing trials for the overlap, so that to understand that there is a problem like that and to determine treatment and all that, you needed a terminology, and they continue with the terminology asthma COPD overlap. Now, after some time, by 2021 or so, 2020, 2021, even the term asthma COPD overlap started getting attacked. So it was a 2021 gold report. If you look at it, they very clearly said that we no longer refer to the term asthma COPD overlap. And instead, they emphasize that asthma and COPD are different disorders. They may share some common traits and common clinical features like eosinophilia or airway reversibility. And if asthma and COPD coexist in a patient, a concurrent diagnosis of asthma is made, and the treatment generally should follow the asthma treatment. And then you might add on to, whatever COPD treatment is needed along with the asthma treatment. So then, Gold came down heavily on the terminology and said that we no longer would recommend that terminology, and the terminology should not be used. The current Gold, the 2024 report also, if you go with it, it says something similar, that we no longer, same statement, that asthma COPD overlap is no longer referred in Gold. And they emphasize again that these are different disorders, and so if COPD and asthma coexist, you go with pharmacotherapy of asthma along with whatever is needed for COPD. Now, COPD guidelines, as you know, in the last few years, have also started talking of ATO types. And if you look at ATO types, slightly different, I'm deviating a bit, but then again, coming back to it. So if you look at the COPD-A, that is COPD and asthma, so a person who is having childhood asthma, later developing COPD. So obviously, this GOLD guidelines, even though has taken out the ACO terminology, brings in a new ATO type where asthma and COPD actually are a continuum of the same process. So the person has asthma as a child or as a young adult and develops COPD later in life. So obviously, both of them are present. And of course, they also say that there could be considerable overlap also. Now, GINA guidelines slightly, kind of differ from what Gold says. So if you look at the latest GINA guidelines, here still the terminology asthma COPD overlap is still there in many parts of the guideline document or the workshop report document. So they clearly say that distinguishing asthma from COPD may be difficult, particularly in older people and smokers. And they use kind of two terms can be used, either asthma COPD overlap or asthma plus COPD can be used to identify this group of patients where these features of both these diseases are present. However, they again insist, as they did in 2018, that these do not refer to a single disease entity. So patients with various clinical phenotypes are there, which with the various underlying mechanisms. It's more of both these diseases occurring together. And they again re-emphasize that more research is needed to better define these phenotypes and mechanisms and to decide what is a safe pharmacotherapy for such patients. So that brings us to the last part of the talk, where we talk about the treatment or the management part of asthma. So management of asthma, as you all know, you have the stepwise treatment. And if you look at step 5, from step 1 to step 5, both for your track 1 and track 2, which are the two tracks that we have in asthma management today. At all points, you have to give inhaled corticosteroids. So, even the reliever medication in track 1 is a ICS formoterol, and your track 2 is a ICS with SABA. So, wherever, even for reliever medication, it's anti-inflammatory reliever medication today. So everywhere corticosteroids have to be used. So there is no treatment without corticosteroids for asthma. But then if you go to step 5, sorry, go back a bit, step 5, in step 5, you can see that you can add on a LAMA, and the alternative treatment given at the bottom of the table, even in step 4, you could actually add a LAMA to your treatment. So there are circumstances in your asthma guidelines where your patient might end up with a ICS LABA LAMA combination. So that is there in asthma. And when you go to the COPD guidelines, of course, this is a trick question. When you have a COPD case for your examination and the examiner is asking you, how will you manage this patient? And immediately, often what happens is candidate jumps to the pharmacotherapy. With COPD, we have to understand that therapy is both non-pharmacological therapy and pharmacotherapy. And the initial management includes non-pharmacological treatment first, including, smoking cessation, vaccination, lifestyle modification, exercise, and then the initial pharmacotherapy comes, which actually looks at the ABE table. And in the ABE table itself, there are circumstances. So generally throughout this ABE table, you can see it's generally broadly bronchodilators all over, either a single bronchodilator or a combination LABA-LAMA bronchodilator. But then you have circumstances where you have a LABA-LAMA ICS, generally looking at blood eosinophil counts and exacerbations and all that. However, even if there is asthma overlap, you might consider a ICS along with your LABA. So the point to remember is your asthma patient should all be getting a corticosteroid, and your COPD patient all should be getting a bronchodilator. So if you treat asthma with a LABA-LAMA, obviously that is a wrong treatment for your patient. And if you're treating a COPD with a ICS LABA, something like that, it's a wrong treatment. So when it comes to your overlap, how do we manage? One would think that you have to manage asthma, so it's a more of a severe disease that comes to us. So you might start with ICS LABA probably, and maybe add a LAMA also. So would your patient end up with a triple therapy, or would it be enough to give a lower level treatment with ICS LABA? And it's a issue. It's not very clear. And then if you have COPD along with that, then you have to manage go with the non-pharmacological management also, including smoking cessation, vaccination, exercise, pulmonary rehabilitation, each of them important. So this is how you go about it. The importance here is that the prognosis for asthma, COPD overlap, whatever name you call it with, is more worse than a patient having a COPD alone or asthma alone. So this is an entity which needs more careful management, more careful handling. But then the fact is, the issue of what we would actually call it. So I'll conclude, just run out of my 20 minutes. I conclude by saying that, there is a significant proportion of patients with asthma or COPD who have features of both these diseases. But still, as of now, with all the documents taking us here and there, there's a bit of lack of clarity on the terminology we can use to describe these kind of cases. So we started with ACOS, we later started calling them ACO or ACO. And then, the current GINA even talks of asthma plus COPD. So what would be the right terminology is something that, needs more of debate. But the fact is that there is considerable overlap. It is an entity which is definitely present in clinical practice. The proportion varies from place to place, but definitely it is there. And also we know for sure that the prognosis is worse than the patient having either asthma or COPD alone. There is no clear consensus on the management. Studies are not, to that extent as you get for asthma alone or COPD alone. But generally, guidelines suggest that you manage as asthma with added pharmacological or non-pharmacological management, which is needed as per your COPD management guidelines. So these are the facts that we have in front of us, and I'm sure that we'll have a fruitful discussion on that. Thank you so much. Just probably exceeded by 1 minute, Nitin. So kept to time. Thank you.
Absolutely wonderful, Dr. Sanjeev. And you have made our confusion more confusing. and well, I mean, I'm not really going to propose a very that this is a very confusing topic and it will end with confusion. No, not really. But at the same time, I think you have brought all the controversies which are there. And particularly the controversies get created by literature and guidelines. And then eventually, I think hopefully somewhere down the line, the literature and the guidelines and the evidence finally sorts it out. But I think this is a journey in progress, I mean, work in progress. And let me introduce my panel today, which is going to throw more clarity as on to how we are approaching this whole thing, in which way and what is the right way ahead. So let me start with Dr. Radha Munje. Can I have the slides of individual panelists? While the slides are coming on, the tech team, can you display the slides, please?
Yes. Is it visible to you, sir?
Yeah, that's right. First of all, let me thank the ICS, Dr. Sandeep Salvi, the president, Dr. Prashad, the secretary, and Amita, as always, who has been behind this entire ICS webinar series for being this. I also thank Lupin for their non-committal participation, and I mean, unconditional participation into this. And let me introduce the panel one by one. Can I have the next slide, please? Sanjeev, I have already introduced, so go on to the next one. And yeah, this is Professor and Head of Respiratory Medicine, Dr. Radha Munje from IGGMC Nagpur. I don't have to really go through the entire details. This will take us the whole evening, but at the same time, extremely experienced clinician, very well uh, mm, published adequately, and at the same time, one of the most loved teachers from Nagpur, Dr. Professor Radha Munje. Welcome to this panel.
Thank
Can I
you.
have the next one? Thanks, Radha ma'am. Next one, please. Next, or shall I be will you have the next slide, or yeah, I'll let me introduce the panel. Yeah, Dr. Parmez AR, who is a senior consultant and head of pulmonary medicine in Lisi Hospital, Kochi. He's been with the ICS as governing body member for the ICS, secretary for the Kerala chapter of Indian Chest Society, vice president of Cochin Thoracic Society, and so on and so forth. He won the recipient of Best Young Pulmonaries Award from Academy of Pulmonary and Critical Medicine, APCCM. And I mean, we have a wonderful academician coming from Kochi. So, Dr. Parmez, welcome to this gathering.
Thank you, sir. Thank you. Good evening, all.
Good evening, everybody, and good evening, Parmez. Next one, please. I'm also inviting Dr. Aarti Shah, who's won the DNB National Board. She passed her DNB National Board in 2009, DTC in Saurashtra, from Saurashtra University in 2003. And of course, she's currently the professor and head of Department of Respiratory Medicine, in charge of COVID-19 Care Coordinator MEU. She has 20 publications, presentations, and 37 publications, and has won 5 awards. So welcome, Dr. Aarti Shah, for being with us today. Thank you very much, and welcome on the board.
Good
Next
evening,
one.
everyone.
And last but not the least, Dr. Shikha Jindal Gupta. She's MD, FISDA, EDRM, like me. You are one of my kind here, and also has CTC, as you can explain that eventually. What is that in 2023? Present designation and affiliation. She is a senior consultant at Neo Super Specialty Hospital, Noida. And she is interested in one of her interested areas, of course, is OID, apart from the IP and sleep medicine and tobacco cessation and so on and so forth. She is a gold medalist in medicine, presented papers in national and international conference, part of number of research trials, publication, national and international journals, and fellow in sleep medicine, NCCP, ICS, ERS, SSAP. So welcome, Dr. Shikha. Wonderful to have you on this.
Thank you.
And thank you.
Good evening to everyone.
Can I speak something, Nitin?
Yes, Radha ma'am.
Actually, it should have been your introduction first. So I would be just taking half a minute to introduce our moderator today. He is none other than Dr. Nitin Abhyankar, a great pulmonologist from Pune. And we all know him as one of the most sought after faculty everywhere. So if Nitin is not in his IP suite, if he is not delivering a lecture, then we are lucky to have him on our webinar today. I think we are very lucky to have him here. He is a very sensible pulmonologist, but at the same time, I must add that he's a very sensitive person, which makes him write prose and poetry with such fluency and a flawless writing he has. And I think he writes in all three languages, Hindi, English, and Marathi, and even makes people not dance but sing to the tune for what he has written. And I'm sure most of our delegates, I mean, all of us, including the panelists and those who have logged in, have already heard Nitin somewhere or the other. And we are so happy to have him here as a moderator. Nitin, you can go ahead. Very sorry to interrupt your flow.
No problem, ma'am. The flow is not interrupted, but is enhanced further. Well, at the same time, well, I'm not as good a singer as she says it is. She says I am, but at the same time, well, I mean, let me start asking her the first question. And Dr. Radha, ma'am, what, in your opinion, is the ECOS or asthma plus COPD, whatever you want to call it? And what percentage of patients in your practice have this so-called overlap?
Um, So actually, I know you have placed the first question to me to make it a little easier, but I think the question is difficult. As Sandeep has already explained to you how the term ECOS and ECHO has evolved over the years. And way back in 2014, it was a well accepted and had a recognized definition in the document which was jointly published by Gold as well as Gina. But the first and foremost, we must understand that presence of COPD or diagnosis of COPD is a prerequisite. As of now, in 2024, Gold does not mention asthma and COPD overlap. However, GINA continues to have this nomenclature of asthma COPD overlap, and it is collectively used to describe the patients who have persistent airflow limitation. So in this definition, and there is a wonderful review available over ECHO where the definition has been consolidated. And the first part of the definition which says is that the patient is diagnosed as COPD with the diagnostic criteria of FEV1 by FVC less than 70% post bronchodilator. That is one. Secondly, the person is elderly, that is more than 40 years of age, and that definitely has history of either smoking or exposure to the either the what do you say, the pollutants or the other biomass fuels or something like that. So that exposure is there, and on the top of that, they show variability in their bronchoconstriction, or when you look at them, they have multiple exacerbations. And if you do spirometry, they may show a good reversibility, which you otherwise did not expect in patients of COPD. So that is what we have as asthma COPD. So that is the first part of the answer. And the second part is what is my experience. And here I'm really happy that for the first time, whenever I'm talking, or it happens very few times that you have really worked on a particular topic. So we have already done a study which was presented in one of the union conferences, which concluded that we did DLCO in these all clinically evaluated cases of echo. And we found that those who have asthma predominant symptoms or features had normal to increased DLCO, whereas those who had COPD predominant features had decreased DLCO. So that was what we found, and the percentage of occurrence varied from somewhere around 10 to 30%. And this was quite recent, it was presented in 2022. So we did it almost 2-3 years
So ma'am,
before
10 to
that.
20, 30% of what? I mean, what was the denominator? I mean, the entire obstructive airway disease basket, or out of your COPD patient or out of your asthma patients?
No, these patients were COPD patients which we assessed in the OPD. And once we knew that they were falling into this bracket of echo, then we went ahead with doing their DLCUs.
So your denominator was COPD essentially, and
Yes,
then
yes,
10 to 30% of them were actually asthma COPD overlap.
yes,
Is
yes.
that right? Yeah, yeah, because I think that makes a lot of surprise, but at the same time, makes a lot of sense because I belong to Pune and I belong to Sandeep Salvit city, and we know that non-smoking COPD is the term which is become worldwide renowned because of the person called Sandeep Salvi, and I think
Yes.
he has put this into into the right perspective, and that's what we when we went to ERS in 2009, that's what we were trying to say that look, the first stuff, when I look at the lung functions on the first time when the patient is encountered by us, the lung functions look pretty poor. They look not so reversible. They are maybe partial reversibility, but almost no reversibility. But you treat them with ICS, LAMA, LABA, whatever that combination that I will use, whether I'm using a LABA, ICS, whether I'm using a triple at that time, they were like not SITTs, but they were like MITTs. So multiple inhalers in triple. And after 3 months, we found that good 30%, exactly what the percentage that you showed, had actually moved into a normal lung function zone. So that meant that these were poorly treated asthmatics, and this, I will call it echo, one way or the other, whether you want to call it poorly treated asthma with a fixed
Yes.
airflow limit, whatever the definition, whatever your terminology is acceptable. But the fact that on day one, we should not make the decision as to what is this. Is it
What
pure
is this?
asthma? Is it pure COPD, or is it a so-called echo in the true sense? Of
Yes.
course, some
Yes.
patients will remain, and I'll now I think move on, because if I keep speaking, I'll be speaking too much. So let me ask this question in Dr. Parmez, in your opinion, where do you place them? What are the real differences between asthma, COPD, and echo?
Yeah, this is the exact pathophysiology that we need to think about. As Sanjeev sir mentioned, when we were doing the PG postgraduate, and as far as in the pathology textbooks, we were actually mentioning about the chronic bronchitis emphysema part of COPD, and then whole perspective changed to a clinical diagnosis and management kind of thing, rather than going away from the pathophysiology or the pathology. So probably we are actually coming back to the era where we just need to concentrate on the treatable traits aspect as well. So considering that, coming back to the question, asthma definitely a childhood disease mostly, and with a genetic background and all. Reversible airway obstruction will be there. Some amount of atopy is there. So basically, it is most of the patients will be having a T2 type of pathology. And as compared to COPD, which most of the patients will be elderly, will be having any history of exposures, and will be a partially reversible or a non-reversible airway obstruction. And I'm getting some disturbances. Yeah.
Yeah, I think.
No, I'll proceed with that. Regarding the COPD, the elderly aspects and patients as well. But when it comes to echoes, the question that we have right now is whether not a properly treated asthmatic patients going into a non-obstructive airway function does fall into an ACO category. Pathophysiologically, no, actually, because it has got a pathology of asthma only. But when you see the PFTs and all the spirometries and all, then and all as Radha Madam mentioned, the exposure history will be there for most of our patients in India. Some kind of exposures will be there. But to be frank, asthmatics from childhood growing into a COPD kind of airway, I won't categorize into an asthma COPD overlap. But yeah, if you go retrospectively, as Madam mentioned, in COPD patients, when you analyze for the history of allergies and history of exposures, history of reversibility, kind of thing, that you find that this particular individual is a COPD and you do the PFT and you are getting a reversible airway obstruction, then you'll be amazed. And when you do the bloods, you may get a eosinophilic predominance and also maybe some kind of atopic, which may be hidden also. So I would say we screen more of COPD and we may get more amount of ACO in our clinical practice is what I think in my clinical practice. And as Madam mentioned, I was going through an article in 2021, the major criteria and the minor criteria of diagnosing this thing, where if you have got a good amount of exposure history, if your age is more than 40 and exposure of either cigarette smoke or environmental exposure, household smoke or something like that, with good amount of reversibility to the tune of bronchodilator reversibility to the tune of 400 ml is a major criteria. And if it is to the tune of 200 and if you are having a blood peripheral eosinophilia, these are all taken as a minor criteria. So in asthma COPD overlap, we can emphasize more on a chronic bronchitis kind of patients rather than an emphysema kind of patient is what I believe. Mostly the pathophysiology will be in that regard. There may be some amount of debate, I hope so, but what I believe and I put forward my thought process in this regard. Thank you.
Yeah. So you mean to say that somebody who's massively air trapped is not likely to be echo, but a pure emphysema?
Pathologically, it may not be, but yeah, we may need to treat them like echo because, as Sir mentioned, most of the echo we have to treat it like an asthmatic. So
I think
but yeah, clinically yes, but pathophysiologically it may not be. So what exactly is the pathophysiology is the question.
Yeah, so let's argue that further with Dr. Aarti, and let's ask her about what do you think the lung functions tell us when we look at echo, or whether, I mean, how can you differentiate echo on the basis of lung function?
Sir, this is really a good question. First of all, we want to understand really why we want to differentiate this disease from the other diseases. We want to know whether asthma is having COPD or COPD is having asthma together. So, as we first of all go for spirometry, sir already mentioned that FEV1 by FVC ratio less than 0.7, then reversibility is there. So, as we know, good reversibility, we can add steroids, that is there. Then second,
and what's your definition of good? 10%, 15%?
Yes, yeah, definitely. This is like more than 200 ml and 12%. And so added to it again, if it is clear cut more than 400 ml, then definitely we need to think the component and like inhaled steroids should be there. So that is the important part in that. So
Yeah.
next,
So I think a significantly large reversibility, either 15% or more, or 400 cc or more, possibly goes a little more towards it. What's your take on the newer techniques? Can I ask you that?
Yeah. I was moving to like second ma'am told us about DLCO.
Yeah.
So DLCO, madam has given one new point that if asthmatic component is more, then DLCO is a little on a higher side.
Likely to be normal.
Yeah, likely to be, yes. And if it is low, then okay, we are dealing with more of a COPD. So that will be there. Then,
but then that has to be a severe and a very severe zone where the DLCO starts actually deteriorating in COPD.
Yes, sir. But as you know, so, we practice in medical colleges and we get those kind of patients only.
Absolutely.
So, yes, sir, absolutely. And now, as you said that, what about the newer things, pheno? So if pheno, if it is, yes, sir. If it is high, then yes, asthma component is more. So
In fact,
along,
I had, yeah, okay. We'll
yes, sir,
go to Sanjeev after that because I had a question for Sanjeev on the
okay.
inflammatory part of it. Yes, please go on. Please go on. You finish your.
Okay. So this three things, if we are thinking about the disease, then we have to see all these three things also, sir. Because by seeing ACO, like asthma COPD overlap, we want to know which component is more. Asthmatic component is more or the COPD component is more. That is, I think, our aim to understand while treating it. That is what I understand when we analyze the lung function test also, sir.
Absolutely. Yeah, I think very interesting that you still are not coming, despite me probing you on the newer techniques. You have not mentioned either iOS or FOT.
Okay, sir. Actually, sir, I'm not the right person to talk about FOT because I'm not using that much. You can go to the experts for that. Yes, I know that FOT is telling us more about small
Small
airways also.
areas.
Yeah, and it is very easy to do. So you can add to it.
Yeah. No, I'm not really an expert, but I'm an enthusiast. And after doing 3,000 nearly, I'm more an iOS man. I just have acquired an FOT in my own clinic. So I have an iOS and FOT in my clinic. I have the luxury of having both the techniques. But at the same time, this is a very interesting field which is emerging. And the reversibility, which is completely lacking on a spirometry, often is so dramatic on the R5 going down by 40%, or the AX going down by more than 40%, or the R5, R20 difference going down by more than 25%. All those components are so very visible on, on iOS or FOT, and they are not at all picked up by the spirometry. The spirometry shows maybe 4%, 5% increase in the FEV1, and we are stuck at that particular level. Or sometimes the FVC increases, but it's not complete.
If it
And
doesn't.
unless until you do a RVTLC, you're not really seeing the complete picture. And RVTLC is a forced maneuver once again, and not everybody is able to complete. Whereas a iOS or an FOT is a much easier tool, and people are able to do that. I am going to take that a little ahead, and I think we'll come back to, I think we'll go to Sanjeev first, because you mentioned about FINO. Sanjeev, your take on this, and then I'll go to Dr. Shikha about the radiological findings. But your take on FINO, where does it fit in this
Yeah, I guess
echo algorithm?
FINO was something that was very exciting for us, and we actually looked at FINO as a biomarker for determining differentiating between asthma, COPD, and ACO. In fact, we also did a study on that initially, which we presented at the European Respiratory Meeting, and statistically there was a difference. Statistically significant difference was there between COPD and ACO, not so much between asthma and ACO when you looked at FINO. But the only issue is that, as with many of the other inflammatory markers that we did, we actually studied three of them. We looked at FINO, we looked at blood eosinophilia, not to that extent. I mean, sputum, we didn't have a standardized testing, so we could not look at sputum eosinophilia. A bit of IG, it was too costly for my patients, so we could not do it that much. So these are the ones that were mentioned. But FINO we did do, and we found a statistical difference. But the point is that even in our COPD patients, some of them had elevated FINO. So out and out COPD also, some of them had elevated FINO. The asthma had elevated FINO. So at
Particularly
the
those
end,
who have an allergic
clinically to
rhinitis.
differentiate between them,
In,
it didn't work
in
out
fact,
to our
Sanjeev,
satisfaction.
I am an allergic rhinitis
Mm.
fellow, and
Mm.
my FINO is always 45. And I have never had asthma in all my life, very frankly.
Yeah.
So, I mean, one way or the other, the FINO is a. I'm not yet convinced. It will take some time for me to get convinced on the FINO part of it. But I absolutely agree with you that eosinophilia, blood eosinophilia, simple. You can't realistically go for sputum in all cases because that requires more like a research team and a very dedicated person like Angira Das Gupta, somebody like that, who's totally driven and has the resources. You need a lot of infrastructure for that. So I think
I
let me take
think,
this.
yeah, just to add on, Nitin, the
Yes,
only
please,
issue with
please.
all these biomarkers in a study mode, you can find out statistically significant difference. But then these
Yeah.
are, kind of up and down in all the three groups. So from a
Yeah.
clinical
Making a
perspective,
clinically
using them to
meaningful
make a
decision is so
diagnosis is
tough.
quite difficult.
Yeah. Clinically meaningful decision is very tough. Only just looking at a single biomarker and say, okay, fine. Pheno 50 and okay, this is asthma, end of the story. That doesn't really work out. And most of my badly controlled asthmatics do not show as, so-called, I mean, the FEV1 is down to 30% and I still don't get a pheno going above 25. So that leaves me in a, middle zone. Shika, I'm coming to you. We have left you behind for a long time, but you are not the last, but not the least, but the last in this question answer session. Of course. What do you think are the radiological features which are linking you towards or leaning you towards echo? I think somebody mentioned about air traffic already.
I don't think that ECOAS has any kind of a specific radiological feature as such. It does not differ much from asthma or COPD. So in case of radiology, if we come to a simple X-ray as such, you might see hyperinflation, especially in patients who have a COPD kind of a predominant feature. So hyperinflation can be seen through your flattened diaphragms, or increased retrosternal airspace can be there, or increased hyperlucency of your lung parenchyma you can see. And if it has more of a bronchitis or a asthma kind of a thing, you can see an increased bronchovascular marking due to airway inflammation. And if you come to CT scans, if you want to see, where you can always see subtle changes or the more extent of disease and such, patients, because it's an airway disease, there is airway inflammation. So you can have air trapping. You can have an air trapping, especially on the expiratory cut, and you can see the mosaic attenuation. And also you can see, look for the airway wall thickening, which can be well seen on the CT because of the chronic inflammation as such. And especially in patients with smoker, you can also find centri SNR emphysema changes on the CT scan. At times, you can also see bronchiectasis, especially in patients with chronic bronchitis. Over the time, because of the airway inflammation, they can develop tubular bronchiectasis. So these are the signs, but these are the signs which are nothing specific of ECOS. This finding, you can label it as ECOS. So I don't think that this is there.
I think you're spot on and you've described most of the important signs very well. Let me take the first question and then go back to Radha, madam. First question from the audience is one of the, how to manage overlap, that is echo and pneumonia with respect to steroid. And the second question Dr. Siddharth Mishra asked is how to manage overlap and pneumonia with respect to steroids. Sorry. I think that's
the same
repetition of the same. Yeah, same question. And how to manage, this is important. I think Jaya, I can't realistically pronounce that, Nadu Villapat Fisher. I hope I'm getting the name pronunciation right. Sorry about that. How to manage a patient with echo who is on a maximum dose of bronchodilator. So I think, Radha ma'am, I'm going to ask you for how do you initiate treatment? And this may be answer to their question.
I hope that when I'm speaking, probably the questions there are answered. So first and foremost, as we have been discussing now, that most of the data comes from trials, right? But still, in spite of that, the evidence is very limited, especially when we talk about the treatment. So whatever treatment you are going to adopt for that particular patient, that decision should be based on the phenotypic characteristics and the symptom severity with what the patient is presenting to you, and what part of the symptoms are not getting relief when you have been either treating the patient earlier or patient was being treated by somebody else before he came to you. So that is very important. And then I would always prefer, even if it is not there, what Sanjeev has already shown, that you have those major minor criterias. Let us check off the major minor, but all those points are very important to make a diagnosis in echo, that which type of disease is predominant, whether it is asthma predominantly or whether it is COPD predominant. That is important. And once you have done that initial assessment, then you go to the stepwise treatment approach. Sanjeev have already shown the guidelines from the GINA and GOLD. So for patients who have mild asthma features, inhaled corticosteroids are typically sufficient. Plus, you can add a bronchodilator to it. That is indicated, and especially if the patients have had recurrent exacerbations and elevated blood eosinophils. So, I think a patient who has COPD and is not responding or is having recurrent exacerbations, but has features which suggest that there may be some element of asthma in this, then it's better to put the patient on inhaled corticosteroids. Traditionally, you treat COPDs with LABA/LAMAs, but here you are adding inhaled corticosteroids. A combination therapy along with LABA is added to your pre-existing LAMA monotherapy, or if your patient has been, as is being given only LABA. It still happens, like we are very fond of talking, and now we talk more about triple drug therapy, but even now your patients are getting monotherapy. So assessing what treatment patient was getting and adding ICS at the right place, or even adding LABA if it was missing in the prescription, is needed. And of course,
so I think
now that
can we make a statement which I think is the most non-controversial, that a monotherapy with LABA is largely contraindicated when you are talking of
yes,
echo.
yes,
Yeah.
definitely. And if control is
Because
inadequate,
it's very difficult to make sweeping statements here today. But I think this
yes,
is one statement I think we can take as a take home, that a monotherapy with LABA, a no-no in
yes,
echo. Because I'm
and
suspecting asthma in that,
right,
and ICS be there. So at least
must
LABA
be
ICS
added.
minimum.
Yes. And especially in cases who have recurrent exacerbations, you have to ensure that all three drugs which are indicated for obstructive airway disease, be it ICS, LABA, and LAMA, all triple drugs need to be advocated, and the dose has to be prescribed, and you have to ensure that patient does not pick up any one of that. And then you have, I'm just going to touch, and I'm not going to talk about it because it's a topic in itself. Apart from this, there may be a time or a case which may be needing, uh, you know, um, patients may need monoclonal antibodies, or a
Yeah,
Montelukast
I have
needs to be
questions
added.
coming up for that,
Yes.
basically. So
Okay.
we are
So
definitely.
I won't touch
So,
it. But
yeah.
last, before I sign off, Nitin, do we add a
You
note
don't have to
on?
sign off. We'll keep you engaged
No,
all the
no, I
time.
mean,
So don't.
sorry. When I finish my answer, we have
Yeah,
to see to it that the question which was asked was with pneumonia. So I
yeah,
think if a patient is admitted with pneumonia, there is no contraindication to the use of inhaled corticosteroids. In
true.
fact, many times if the patient has, fulminant pneumonia, septicemia, in at that time, you even use parenteral corticosteroids, and
Anti-steroids are not
that
contraindicated.
is actually life-saving, and helps a lot. So I
I
think
think
he got the
very well.
answer that he wants, that you
Yes,
have to
I
treat
think
the
you.
exacerbation as well as the pneumonia.
Yeah, and you treat it on the merits and the guidelines which are existent for the rest of the pneumonia component of it, or the
Yes,
obstructive airway disease component of it. So
yes,
echo,
yes,
I think echo you will sort out only over a period of time. First time when you see a patient, you probably may not be making that as a final diagnosis. You will look at obstructive airway disease with an exacerbation, and it could be
yes,
infective or effective. So depending on that,
yes,
you will say. Parvez,
yes.
let me come to you on the
The only
so-called
thing,
non,
Nitin,
I think often
only thing in
neglected.
this,
Sorry,
sorry,
you could.
the
That,
only
yes.
thing in this question was that the problem of infective versus non-infective exacerbation was not there, because pneumonia is clearly
Yeah. So the
visualized and
moment you say
diagnosed.
pneumonia, I'm assuming it is infective, at least mild,
Yes,
if
yes,
not a
yes,
bacterial pneumonia.
actually.
So one way or the other, you will probably, when you say viral, coexistent secondary bacterial infections are anticipated, and and the enchilada of the whole story, whichever, with antibiotics, antivirals, and appropriately treating with an
Yes,
optimum dose of steroids. I wouldn't load them with, say, methylprednisolone 1 gram. That is not going to happen in this scenario, but an appropriate dose as indicated by the guidelines at that point in time. Always,
Yes.
let me come to you on this, on the non-pharmacological treatment of echo. Is there something called that existed?
Yes, definitely. But before that, coming to that topic on pneumonia and
Yeah,
echo,
you can please elaborate on it.
yeah, because it's the usage of steroids in pneumonia. Anyway, because there are lots of trials happening and coming into the sepsis guidelines, whether commit or not, or whether it will be incorporated or not, is coming in a big way. But yeah, means as far as an asthma with a pneumonia, definitely we don't have any doubt in initiating a systemic corticosteroid. Anyway, in a COPD with this thing pneumonia, then we may be a bit skeptical. But in ACOS also, I think we may be. It may be beneficial to start systemic corticosteroid along with the appropriate antibiotic coverage
Antibiotic.
is my take. Especially when your sepsis, the inflammatory markers are on a higher side. I usually take it as a cutoff of 150. If it is more than 150, yes, you can have a good clinical improvement, and your patient's ICU stay may get improved in a patient with asthma as well as ACO with pneumonia.
Yeah.
As far as the non-pharmacological treatment part, yeah, anything, sir? Shall I?
I really, very frankly, I'm not able to think of a single thing, pulmonary rehab. There is a
Yeah, I am
question on
coming to that.
oxygen
Yeah,
therapy. And I think
I am.
you can probably answer that, because what
Yeah,
are the
I'll come
angelic,
to that.
what are the benefits of and limitations of oxygen therapy in echo patients? Is there something like that? I mean, oxygen helps everybody who needs it, in my simple, humble opinion. I mean, so Anjali is asking a question whether you use oxygen therapy in echo patients or not.
Definitely
And are
means
there any
as far as
limitations or
the non-pharmacological therapy is concerned, especially we are dealing with patients who are either middle-aged or an elderly set of people, which who are having definitely less amount of muscle function as compared to the younger age group. So focused pulmonary rehabilitation has to be there. Proper nutritional support has to be there. The guideline on vaccination has to be screwed into their head that they need to get vaccinated with all the available vaccines to prevent pneumonias, the flus, COVID, if God forbid, if comes again and all, and the other COPD, wala, Tdap, and Shingrix, etc., if
yeah.
they can afford. That is
So I
one
think
thing. So the
once again, I
non-pharmacological
think
treatment,
we
definitely.
can we can make that as a sweeping statement of the day,
Yes. Yes, it
that
definitely has to be.
all relevant vaccinations are
Yes.
indicated in echo
Yes.
patients. There is
Yeah.
no
Yes.
confusion on that. All relevant. Whether you want to give
Yes.
influenza, yes, no, yes. Pneumococcal, if you think the patient qualifies for
Yes.
it, yes. Shingrix,
Yes.
if you think the patient
COVID,
qualifies for it.
Shingrix.
RSV,
Yes.
when it comes in, yes. So I don't think there is any contraindication to vaccination. So I
Yeah.
think that non-pharmacological therapy is absolutely non-controversial. The remaining depends on case-to-case decision. I think
Yeah.
it depends on whether somebody is really debilitated, whether he will benefit by rehab or not. It depends on your call on the whole story. And I think that we can leave it at that. I guess the non-pharmacological component of
And
it.
and as far as the oxygen therapy is concerned,
Yes,
as Sanjeev Nair sir mentioned, this particular set of group of individuals will be having more severe kind of ailments. So you always need to
yeah,
think in lines of COPD, whether this particular individual is meeting the criteria for a long-term oxygen therapy. That is one thing. Whether this particular individual is developing a pulmonary hypertension, whether any peripheral edema is developing or not, whether he is having a recurrent exacerbation, whether he is dyspneic at rest. All these criteria of COPD to initiate LTOT will fall into ACO patients as well, as far as the initiation
correct.
of oxygen therapy is concerned.
Yeah.
This
But
is my
I
take.
would suspect that many of these so-called echo patients, because they have a component of asthma, many a times they may need initial oxygen, but they may grow out of it.
It may be
Absolutely.
a
Over a
reversible
period of
oxygen
time.
therapy as well.
If there is a reversibility component
Yeah.
which is hidden in the upfront, and eventually it emerges that yes, I mean, the lung function improves by 40%, 50%, and then they may be much better.
Yeah, always
Aarti,
reassess the patient for withdrawing the oxygen as well. Maybe
absolutely.
on a 3 monthly interval and all, to see if we can come down on the oxygen therapy as well.
Absolutely. In fact, one of my echo patients, I had the misfortune of prescribing and telling the patient because the CO2 retention was so high. The CO2 was 88 and it stayed that way for 2.5 weeks. And I ended up saying this person needs lifelong non-invasive ventilation. Now, this was 20 years ago. I was not that experienced. And after one 5-day course of injectable steroids, the patients had a PCO2 which was down to 40 and the PO2 at normal. And I had to eat my words. And I almost got, a castigating later, 30 pages later from saying that you had put me on this kind of a machine for what? I mean, well, I mean, the young people tend to overdo things and it happened to me also at that point in time. Aarti, let me come to you on this little controversial component of biologics in this. And in fact, one of my echo patients, I am a storyteller, so I keep just as I write poetry, I keep telling stories. So I'll tell you one more story and then ask you the question. Uh, One of my patients with everything, the triple, uh, even a small dose of azithromycin, even a tiny dose of oral steroids, went to one of the American consultants and then she said, I give you only two options which are left with me. Doctor has done everything for you. So it is either Tezspire, which is tezepelumab, or dupilumab. So something on the biologicals. Is that something which is emerging? Will it happen in echo? Will it be limited to COPD or what?
So this is like after I think 2-3 years, Indian doctors will be able to tell confirmly that no, we can give this biological in this uh, type of echo. See, as I'm again saying, sir, if bronchial asthma patient is having COPD, and that is echo now. So, if the good history of bronchial asthma, or I can say dominant part of bronchial asthma is there, and patient is saying that he is having definitely variability in the symptoms, IG levels are good, or eosinophil component is high, and definitely the history of allergy is there, then I think we should go for biology. And for biologicals, as itself, like every like component has a different biological. So I will not go into detail of that. So
But omalizumab may be a right choice with that so-called IG elevation,
yes,
and so on and so forth. So the eosinophilic component may get poly, ventrally, and then the newer ones, which may come, Dupi as well as tezepelumab,
yes,
eventually will be available over the next 2 or 3 years. That is what we are expecting. Some
yes.
trials are in fact starting in
Sir,
my own hospital on the newer one, Tezspire, which is
And there is
the
trial
India
happening
trials are
for
starting.
COPD as well, no? Dupilumab on COPD.
Yeah,
yes, sir,
COPD, for the COPD,
So, yeah.
exactly. So
So I
COPD
think
will always have some echo overlap, one way or the other. So Shika, can I come to you on this question? What are the complications of echo? I mean, we are talking of an imaginary disease, and then, I mean, not well sorted out, and then we are saying, oh, it has its own complications also. Sanju, you can also come on this and also on the biologics.
So probably
Yes,
when we talk about echo, so it's an asthma COPD overlap. So we really don't know what is like the exact pathophysiology as such. Probably over the years we'll come to know about the exact pathophysiology of this disease. But if we are considering it as an asthma COPD overlap, so probably there is a mixed inflammation, which includes your eosinophils, neutrophils, and probably because of this mixed inflammation, probably this disease is a little hard to treat as such as compared to an asthma alone or a COPD alone. So therefore the studies have shown, and even clinically we have seen, like in our practice, that ECOS patients have a more frequent exacerbations, they have a more hospitalizations and a faster decline in the lung functions, though they are like controlled with the medication. But if they have, but because of the recurrent exacerbation, probably there is a faster decline. So, and over the time, if we are talking about the complication, because of the faster decline over the time, probably the patient might develop hypoxemia and land upon oxygen, as we have already discussed on that. And other complications could be like cardiovascular events. Patient can be more prone to coronary artery disease, arrhythmias, and over the time, patient might develop pulmonary hypertension leading to right heart failure called pulmonale. And since the patient is suffering from the chronic disease, patient might develop depression, as what we have seen in COPD patients as well. So
I think it's a fairly holistic answer. I think you have covered most of the components of that. Sanjeev, I think before I ask you the same question, a little on biologics, but this is something for you because Jenny has asked a very interesting question. Does eosinophilic COPD or a neutrophilic asthma come under echo?
I did see that question. So I think it's not as simple as that. Somebody having a eosinophilic COPD can be a COPD alone. It could be echo as well. COPD itself, the guidelines very clearly say that if you have eosinophil levels more than 300, you consider corticosteroid. That is not your echo. Just because the eosinophil went up in a COPD, it is not your echo. Similarly, in asthma, you could have various phenotypes of asthma. Just because eosinophils were low in asthma and you have more of neutrophil, that automatically does not become echo. Echo, like we discussed right now, you have a set of features. Based on all that, you make a diagnosis. You don't jump on any one
clinical
parameter.
Story also matters more than just neutrophils.
So everything put together. Now, there was another question on, increasing how much can you increase the dose of bronchodilator. So I think, again, we covered that. In fact, you said that LABA alone would not be used. We also agree that the management would be as per asthma. So you're starting with a corticosteroid. And as per your GINA guidelines, you're going up stepwise. Your corticosteroids are also going up. Then you're adding bronchodilators. By the time you reach step 4, step 5, you are going to have a high dose corticosteroid, you're going to have a LABA, you're going to have a LAMA. Now, at this point, when the patient has got high dose corticosteroid, LABA, LAMA, maybe patient needing oral corticosteroids to control, that is reaching the definition of severe asthma. So I think the same thing would apply to echo as well. As we said, for all other pharmacotherapy, we don't really have trials for echo as such. So, you have for asthma, you have for COPD, and you will reach a stage where you reach that severe asthma kind of definition, and your echo patient obviously would need biological. Now we are talking from two different perspectives, biological for asthma, biological for COPD. I'm sure that sooner or later somebody would come out with trials for biological for echo as well, which as of now we are not very clearly having much.
We don't have a very clear vision.
In fact, I think everybody would be adding a line here that once you reach that stage, the first and foremost you do is start reassessing your patient. Again, go back to the history, again, review all the investigations that you have. Again, look whether patient is really compliant with the treatment. Are there any comorbidities? You are going to reassess your patient before you jump to something else which is yet to be proved.
I think before we make a diagnosis of severe asthma, going from a difficult to treat to severe asthma, you go through the entire checklist and then only reach that point.
Yes, yes.
A little more thought-provoking question by Vivek. What are the benefits and side effects of using oral steroids in echo management? So once again, we are looking at the spectrum where we are at the maximum. We have done everything which is optimal, possibly maximal ICS dose. We are already on a LABA and LAMA in appropriate dosages and still not working. Possibly you are already on azithromycin on low dose and that is also not working. And then you are left with the question mark of small dose of oral corticosteroids. Would you do it? Do you not do it? And some of my patients, or rather,
Nitin, I think,
very frankly, many of my patients are not affording a biologic. So what do I do?
So you reach the stage where patient needs a kind of small or maybe even large maintenance dose of steroids. to actually manage symptoms for the asthma part of it. For COPD part of it, obviously giving steroids,
Yeah.
when
The
you
symptoms
consider
would
risk versus
persist.
benefit, you're going to create, steroid-induced
Correct.
myopathy and worsen the situation. So that
And,
part of it is no go.
and in
But
a
for the
so-called
asthma side,
bronchiectasis
yeah,
with chronic colonization, it's a big no-no.
yeah,
Oral
yeah, yeah.
No.
corticosteroids will be more harmful. But
But
in a
from your
situation
asthma
which
point
would
of
be
view,
more
you will need,
asthma-like,
yeah,
yeah,
yeah. So you would need zero. I
you
mean,
might
that
with a
end of
little
the
bit of a
spectrum,
moderate.
maybe 2%,
Yeah,
3% of your patients, you will need, maybe oral corticosteroid, or rather you start it like a not aiming to stop it, but then you're not able to withdraw the steroids, because the moment you withdraw steroids, patient
the
becomes worse,
patient
and then you have to
exacerbates.
continue steroid. Now you reach
Yes,
the stage, exactly the stage where you have to consider biologicals. But like you said,
Biologicals.
you
absolutely.
may have in Indian scenario, you may have patients who cannot even consider biologicals, and you are also in a, I work in the
Yes,
government setup. I do have a lot of patients like that where I cannot even consider biologicals because the patient cannot afford it. There, they may continue with the small dose because I am not able to withdraw that. But then there is no question of risk versus benefit. That is the, situation where I have no other option. I mean, it's not that I'm considering risk benefit and giving it to the patient. It's risky. I know that it's risky, but then the patient cannot do without it. It's just like many of our other conditions where they have to be given steroids, some of our
absolutely.
forms of interstitial lung disease, or some of the other diseases where steroids are part of the management, and you have to go try to reduce the dose to the minimum. So I think there is no risk benefit there. This is something where we don't have option.
Absolutely. Now, any differentials on your list, when you are looking at echo, and how do you go about excluding? This is one of our planned questions, but I mean, I don't know whether it's
Yeah,
that
I
relevant.
think when you look at the list of differentials, it's kind of
Yeah,
adding on the list of differentials for asthma as well as COPD. So
absolutely.
the
So
common ones
respiratory
that come to mind
bronchiolitis.
immediately are your cardiac
Yeah,
failure, your bronchiectasis. You
yeah,
might miss on lung cancer and all in your asthma patient, thinking that COPD, your
yeah,
tuberculosis in Indian scenario. So all those
yeah.
things add
I
up.
think
Some of the upper
one
respiratory
thing
symptoms
I
may
would
be
not like to
mistaken. Yeah.
miss on is a chronic
Hmm.
bronchial colonization by bugs. And if I
Yeah, yeah,
don't
Yes.
look
totally.
at that and I don't prescribe for it, whether it is a low dose azithromycin or whether it is a nebulized antibiotic or whether it is an appropriate early treatment of a florid infection, one way or the other, I have to know what is the antibiogram
Flora.
of the colonizing organism.
Yes.
And if
Yes.
I know that, I might be able to, triage it better into nebulized tobramycin versus nebulized colistin or whatever that nebulized antibiotic is, possibly in select situations. It's not going to apply for everybody. There is one last question before we wind this up, and I ask you a question on our take home from every one of you. Is I really again it doesn't make much sense to me, but at the same time I'll ask this. Whoever wants to take it, what are the potential benefits? This is Rahul asking potential benefits and risk of use vaping or e-cigarettes in echo management.
Shall I take it?
Yeah, please go ahead.
Yes. Basically, they are not indicated in management of echo. For one. Secondly, they are not indicated is the first one. And secondly, we as pulmonologists, as well as now a common man is well aware about the risk as well as side effects of vaping. They are more associated with pulmonary complication, leave apart COPD. I think with vaping, COPD doesn't come. Other complications, pneumonias, and other things come first, you know. So I think it is a strict no-no, and treatment का तो सवाल ही नहीं उठता. But if at all your patient is into that and is coming to you and you think it is either COPD or echo, the first thing is stop smoking, as it goes with any management of COPD. First word is always stop smoking
Yeah,
or
and I think
smoking cessation,
very
whatever.
frankly, I mean, I have been working into the smoking cessation zone for a very long time. And the so-called nicotine replacement therapy only works in a very small percentage of people who are
Yes.
totally nicotine dependent in that sense. And it acts as I mean, but one way or the other, you have to use either bupropion or varenicline to
Yes.
wean them off that addiction. And at least a good 3 months, trial, and sometimes even repeated trials of appropriate pharmacotherapy may be relevant along with all the psychotherapy, treatment of depression, all that. And then a small component of it may be manageable by nicotine replacement one way or the other. So nicotine replacement doesn't amount to 90% of the management. It is only the 10%
Yes.
of whatever is remaining, that
Yes.
last uh, itch which the person wants to smoke can be stopped by nicotine replacement. So I am not
Nicotine
great, what you say, prescriber or
replacement.
proposer of nicotine replacement therapy in whichever form, e-cigarettes or whatever you are talking about. One interesting question is GERD coexistent with echo, and I mean this possibly can be married to asthma as well as COPD. So GERD and how do you
Right.
co-manage? So anybody
think
can take that.
Yeah, I think as I mentioned earlier,
Yes.
one of the components of, I mean, you are looking at asthma and COPD. One of the major ways of having a good management of COPD is managing comorbidities well. Like you said, it applies to asthma as well, like obesity, GERD, and all works. Management of that works well for your asthma patient as well. But it's more from a COPD perspective that, management of comorbidities, if you're not managing it properly, it leads to more severity and mortality in your patient. So there is no confusion here where you have to manage all these comorbidities. I think be it GERD, be it
Yeah. Yeah, in fact, we see a lot of patients with
obesity,
pure
be it
COPD
any
with an
cardiac whatever.
allergic rhinitis also. So
Yeah,
I
yeah,
think we have to
all
manage that as an
comorbidity.
important comorbidity.
Yeah,
Unless until you manage, you are not going to get better. So I
yeah.
think every comorbidity is to be managed and treated appropriately. So I think let's start with the senior most, and we'll go from Radha madam to, I don't know the seniority level between the others, so it will be random, but I know Radha madam is the senior most. So we'll start with you, ma'am. Your parting
Actually,
messages and yeah, and then from
yes.
everybody else.
Uh, we know it is a different entity and it does exist. But as of now, you do not have much of guidelines. There is some form of evidence by various studies. There have been reviews also available for echo. But to be truthful, we really do not have you can make a definite diagnosis of echo or compartmentalize your patients into that. I think most of the time, what we do is look at the phenotypes of either COPD or phenotypes of asthma that we have. So we need to have definitive guidelines, which we don't have one. Secondly, for management, we do have options. But before I end, I mean, I'm not going to take the whole webinar again. But before I end, it would be important that if one of us takes up this particular study, and since we come from different corners of our own country, perhaps it might be only we who come up with more concrete evidence on echo. Thank you.
I'm sure Sandeep will be listening to us and he'll be very itching to go ahead with his next clinical study, in echo. So best of luck to Sandeep also on that. I'm a clinician, so I'm a very lazy researcher, one way or the other. So anyway, Sanjeev sir, because you are the speaker, so we'll give you the second.
Thank you. So I'll just reiterate what I said. This is an entity which we are known for more than 30 years. So all these issues of nomenclature and all came in after Gina and after Gold came. So this entity is something that we knew even before Gina or Gold. Nitin himself was talking of his presentation 30 years back. So it's something that we knew. So the entity is there, whatever we call it. There are patients who have both asthma and COPD. It's just a question of nomenclature, what we call them, which is unresolved. Otherwise, the entity, everybody agrees that this is there, and it's a need to identify this entity because of say more worse prognosis than any of the both these individual diseases. So we need to identify that. Only word of caution, obviously, is that I still, when I take classes for undergraduates, I will still stick to differentiating asthma and COPD, because I don't
That is
want
the more
the message to
important.
go out that you can manage all your patients together as COPD and asthma without trying to differentiate. It's still very important to manage asthma as asthma and COPD as
Yeah.
COPD. It's only that
In
small
fact,
proportion. Even I think the guidelines say
just
that
to
we need
endorse
to
what you
manage at
said,
a higher level. Yes.
yeah, just to endorse what Sanjeev said, so many cardiologists I know from Ahmednagar were very fond of writing a triple to every obstructive airway disease they see. So at that time, it used to be, the triohale so-called, and then everybody would get a triohale. One way or the other. देना है तो सब दे दो. No, all goes. And well, I mean, now we have different triples and SITT and whatnot. I mean, so much has come into play. But at that particular time, I used to get irritated with it. एक lung function भी नहीं हुआ है, एक spirometry भी नहीं हुआ है, आपने already triple पे डाल दिया उसको. And it's going on twice daily, which was not indicated to be once daily. So that was the story. Anyway, Parmez, your final conclusion.
Just to add
No,
on,
before,
Nitin, so I think
yeah,
when
Yes,
we
yes.
wrote our guidelines for the state, for the PHC level, we clearly wrote that this is asthma for the PHC doctor, this is COPD for the PHC doctor. And if he or she is unable to decide and needs something
Needs a
akin to a
consultation.
diagnosis of ACO, refer that to the higher specialist, and the specialist
Yeah,
makes a diagnosis. I think
absolutely.
that's just the message. It should be. Yeah, Parmesh,
Yes.
sorry for interrupting.
Parmesh,
no.
please.
Before the concluding remarks, I was just wondering. I just got a question because anyway we are dealing with an asthma component as well as a COPD component. While using an inhaler with corticosteroids, that is anyway required for this entity. Is there any advantage of using a micronized form like micronized beclomethasone or kind of
Small
thing?
particle
Because
beclomethasone is the example, classic example of that. Yes. But I think
whether we need to.
I think the answer to that question may emerge from the IOS, impulse oscillometry. What is the
Mm,
percentage of small airway obstruction? I think
yeah.
that's the only tool which can really confidently tell you that look, the small component is 78%, 80%, 90%, and it is changing after the bronchodilator. So the bronchodilator seems to be reaching. If the bronchodilator is reaching and if it is going down, then I still will not go for the small particle. But if it is not
Mm,
reaching, and if it is not reversing, then I will definitely opt for a small particle beclomethasone or
mm,
whatever
mm,
that new molecule
mm.
which will be available in the
Yeah,
future.
molecule.
Yeah,
So I was just wondering, is there any particular role because we were discussing
possible,
upon this
definitely
entity?
possible.
Yeah, and
Particularly
also
when we
means
are doing, and now we are not just phenotyping, but now we are also endotyping them with
yeah.
this kind of a situation. So I think they'll be probably sorted out much better, that those with a very strong small airway obstruction documentable with or without reversibility will be more optimized with a small particle beclomethasone or whatever is the relevant next option which is available. Cyclosinate also is a very tiny particle, so it
Yeah.
can go into the peripheral airways, but it's a weak steroid in one way or the other. So it's not that efficient, very one way or the other. Dr. Aarti, can I come to you for your concluding remarks?
Yes, sir. So, as being a clinician, we all are researchers also, directly, indirectly. I want to just say that these kind of patients also we need to uh, try see like how they are progressing. Maybe after some years, we will be having more good options for them. Like as sir is saying, there are certain trials on biologicals also where they will be like cheaper and all. We are having one subgroup where we can have a good prognosis also. So definitely, ma'am, we all should just see how they are progressing, what are the complications are with them. And definitely we have to divide these patients in three groups. Only asthma, only COPD, and this combined group. So that like we can have open treatment options for them and precision medicine for them. Yes.
I think absolutely taken your point that cautious optimism is my way of when I say echo rather than a very severe COPD. Very severe COPD is not somebody whom I can't do much with. Very frankly, maximize the bronchodilators, use a tiny dose of steroids, and that's it. Nothing else can be offered. Maybe azithromycin, and then maybe the biologics if they are relevant. Whereas echo is probably a more treatable. Therefore, I wouldn't say they are going to do brilliantly because they are more prone to exacerbations. But at the same time, cautious optimism is my way ahead when I say echo. I'm not really depressed when I say I'm making a diagnosis of echo. That's the way I look at it. Shika, last but not the least again, your last concluding remarks.
Mostly everybody has said. Again, probably echo is more of a, as compared to asthma and COPD, is a little bit of a complex disease entity which has been declared for past 20 years. But again, we don't have any kind of guidelines till date. And since the exacerbations are more, the faster decline in lung functions are more, so probably we want to have a more better approach, and probably in near future we might come up with certain kind of guidelines. But what I feel is that what is important right now is that we should actually phenotype our patient, that which predominant disease the patient has, whether it's an asthma or a COPD, and we can just individualize the treatment, like not specific, like this patient of echo, and so all patient will be receiving LABA and ICS. So we can individualize the treatment depending upon which predominant disease the patient has, and probably in near future we might be having better pathophysiology of echo, and so better treatment options. Yes.
I think let me let me announce that we have crossed nearly 1600 logins
Oh my God.
so far. So this is one of the, once again, where best attended webinars, surprisingly, because despite all the, हम बोलते हैं ना मराठी में बोलते हैं सात आंधळे, seven blind people. So we are seven blind people
Looking at
groping
echo elephant.
in the
Any
zone of
echo
echo,
elephant?
and still 1600 other blinds are following us. So I think I think the credit goes to, I think there's a one last question. I'll just see if there's, I can see
No,
that.
no, no, no.
Oh, no, there's just a comment. Truly wonderful webinar, great moderation. I take that as a compliment. I think we have done enough to keep all the blind men happy, and we
Happy.
also remain as happy as we can. With that, if there are any other pending remarks, please make them, or otherwise we are saying a
We
goodbye
close.
from my side.
Close.
So, and before I wind up, 1600 logins. So credit goes to Dr. Amita for consistently doing this for the 33rd time. She is plus 1500. And I think that's quite remarkable. I also thank ICS, Indian Chess Society, and Lupin for this wonderful initiative, continuing with this. And we hope this march goes on and on and on and on. Thank you very much. And a very good night to you, and a very, very happy Independence Day. Of course,
Yes.
we still remember the pain of the lady's life that we lost and our dear colleague. And I think we need to do something more concrete on that also. So with that, a little bit of a side note on that, but we look forward to tomorrow's morning because it's our Independence Day. So
78
with that,
Independence Day.
78. So with that, a goodbye from my side. And thank you very much for your very, very patient listening and having this wonderful panel who made the best out of a disease which is so difficult to deal with otherwise. Thank you very much. Thank you all.